Welcome. My name's Brendan. I'm the COVID-19 lead for the Adelaide PHN. Firstly, I want to acknowledge the Kaurna people who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connection to land, waters and community enduring now as it has been throughout time. We pay respect to them, their culture and the elders past and present. We would also like to acknowledge and pay our respect to those Aboriginal and Torres Strait Islander people from other nations who live, work, travel and contribute on Kaurna country. Mani ngā padni, welcome. So Adelaide and Country PHN in conjunction with SALHN are providing a COVID update for primary healthcare providers. The webinar will be facilitated by Dr. Emily Kirkpatrick and Deputy Chief Medical Officer and Dr. Melanie Smith, GP Liaison COVID-19 Project and Operations from SALHN. Our guest speaker tonight is Dr. Eleanor Wilson. She's the medical lead of the SALHN COVID Care Centre, and she's also a Director of Education and Training. So Eleanor will provide some presentations and as witnessed by SALHN COVID Care Centre and general tips, tricks and practical advice for GPs on managing common COVID presentations via telehealth and referral pathways for patients needing face-to-face review. I will pass over to Emily and she will get through and start this evening's webinar. Thank you.
Fabulous. Thank you so much, Brendan, and welcome. Thank you for joining us this evening for a COVID update, and also really excited to have Eleanor with us this evening to provide a bit of an update on the SALHN COVID Care Centre and the service that's being offered down in SALHN, but also around those practical tips and tricks for managing patients in the community via telehealth, which is incredibly pertinent given we are seeing cases increasing here in South Australia. But before I do commence, I'd just like to also acknowledge and pay my respects to the traditional custodians of the land in which we're meeting on here today, for me here on Kaurna land, and paying respects to elders past, present and emerging. So I'm going to now just put my slides up on the screen and provide a very relatively brief COVID update. Sometimes these COVID updates can get very long if there's lots happening in the time since we've met. However, there's been no real new big policy changes. I'll just check my screen sharing is on. I'm hoping it is. Hoping my slides can be seen. Yep, fabulous. All right. Yes, so we often have a number of policy shifts that come into play. We had the expansion of the antiviral program, everyone over 70 being eligible. We had the changes to the fourth dose, which we presented on last time. And of course, those increasing cases that we are seeing here in the South Australian community, which is really reflecting what we're seeing in the eastern states, probably at a 1 to 2 week period behind. So I'm just going to get started now on the slides, and if there is any technical issues, please let me know. I have had some issues today from an IT perspective, so please let me know. So I'm going to provide a COVID status for today, and particularly these are the numbers that we had, and I wanted to point out a couple of things which I think is just more for interest's sake, and particularly the new cases. So we have seen 3,773 cases today. But interestingly, we are now seeing consistently increasing RAT reporting as positive cases. And we will be having some new messaging that does come out very soon to emphasise RATs can be used for symptomatic patients. If it's a positive RAT, please report it in. You do not need to get a PCR test follow-up. However, if you have symptoms and a negative RAT test, our advice is to then go and get the PCR test. And this is all about trying to increase capacity for PCR testing and making sure the community can get that result back as soon as possible. And a RAT test is acceptable for commencing oral antiviral treatment as well. In terms of reinfections, and this is what I thought was just of interest, 88.2% of new cases now are reinfections, and that's absolutely not surprising, especially with the new updated guidelines that we had a few weeks ago now, moving to a 28-day period for close contacts after someone has had a COVID-19 infection. They are not classified as a close contact during that period of time. But we are certainly seeing an increase there. ICU numbers were a little bit lower, some of the ICU numbers as well, which is pleasing to see. That number does fluctuate depending on the time of day where it is reported, and we have seen that number go up to 16. In terms of the positivity rate, around about 20% of positivity rate, and that's the SA pathology, sorry, that's the overall positivity rate, but we have seen that also be up to 30%, and then it drops down based on which laboratory someone is attending for testing and whether they're attending for PCR testing based on symptoms as well. And I will show up on the screen the SA path data in a tick as well. Now, this is just internal analytics that are undertaken at the RA, and particularly these internal analytics just provide us with a bit of an insight as to where we expect some of those numbers and where they may evolve to over the next 4 to 5 days. Now, you can see here on this particular graph where we've had our hospital occupancy now at its highest level. And you can see that that's sort of trending just above that orange line, which is on that top quadrant. You can see there the active cases, again, sitting very similar to where we were earlier in the year, but keeping in mind, we're at a 7-day isolation period versus a 14-day isolation period at the beginning of the year. So we have seen a change in active case numbers. And that does mean that we are seeing, this is our highest period where we've had active cases in South Australia, noting we're at a 7-day period. We expect again that we will see some increase as well on those cases to mirror the other states. And I'll come to that in just a tick. You can see those ICU numbers just continue to fluctuate up and down. If we look at what's happening interstate, and this is a really good indicator for us as to how we are tracking here in SA, you can see particularly if we look at Queensland's been an interesting state to look at. You can see they've had quite a lot of fluctuation in their cases, and of course this is based on how it's been reported as well. So some days it's reporting changes, but you can see generally still seeing that uptick as well, an uptick in New South Wales, Victoria, and then South Australia there as well. So you can see that will continue to go up and down, but we do expect it is trending upwards, and a good indication for us as well as to how we're doing here in the state. Just before, I did some quick calculations just to see how many patients are sitting in the community at home with COVID versus in the hospital system, and we are tracking very much on par with the eastern states, sitting around about 98.6% of patients in the community being managed, and then we're seeing around about that 1.4 to 1.8% of patients in the acute system. So a little bit higher than where we were before. And we think some of that may be to do with the fact that we are seeing now an older population group impacted by COVID as part of this second wave, and less of a younger population impacted by COVID as well. Just in terms of, and I'm really, really grateful for this, this information from SA Pathology. This is GP referred testing at the SA Pathology sites. And of course, we do also have GP referred testing through ClinPath and ACL, and ClinPath do report on a weekly basis online their influenza data as well. As you can see here, very pleasing. We have seen a drop now in influenza, which is good. It's difficult to quite sort of picture, is it related to the way that we are referring and testing, but we're still seeing those high numbers of tests being performed in the community. So it's a good sign that we really are getting a true detection occurring here around influenza. So you can see we did have that increase, and that's that orange line that you can see, very difficult to see on my screen here. And if these slides, of course, will be available later. And you can see that we did have that peak around weeks 23 and 4 of this year, and now we're seeing that drop off there. However, rhinovirus still circulating, and we expect that we'll continue to see reasonable numbers of rhinovirus, particularly as schools return this week. We have updated that mask advice again to encourage students to wear a mask where possible, particularly in that 12 and above age group. So that's a little bit about where we're seeing those testing numbers at the moment, and particularly where we're seeing the percentage, and pleasing, as I said, we've dropped down to 15% of those respiratory tests are coming back with a positive result for influenza of those that have had a pathogen detected. So that's very, very pleasing to see. Now this, what we're starting to do now is just really trying to get a picture of what's happening in the community with COVID. And we have the National Coronavirus Helpline, as I've gone on and on about at previous webinars. And that helpline is the front door entrance into all of the COVID services that we offer within SA Health, and also now linking in through secure messaging into usual GP as well. So important that we look at Health Direct and go, oh, what's happening with that National Coronavirus Helpline? And again, a reminder, it's a clinician-led service that Health Direct offers specifically for COVID positive patients that just about all of the other states now are using. And they are really have expanded and got some really excellent clinical governance systems in place. So strongly encourage your patients to call through. They're now undertaking the antiviral assessments, and we can see here that where our percentage of cases are being referred for the assessments as well. And we're also undertaking prescribing within our hub as well. And we had, so for instance, on yesterday, this is a report to come out today, on yesterday we had 16 scripts that came out of from our GP hub in SALHN, and a fabulous team of GPs led by Dr. Jenny Gould. And as well, we've had, this is from yesterday's call numbers coming through, we had a reasonable number of calls coming through, around about 80 or so calls coming through to the team. And again, through Health Direct escalations. And then we also have that clinician advice line, and I'll just flag that in a tick. Now, this is the ICC net. I've talked about ICC net before, but ICC net is the virtual monitoring in the community that is available for free for your patients, and also available for patients who are leaving the acute system. And this was the model of care we had in place in the Medi-Hotel for the quarantine program. And now we are seeing a slow increase in referrals going through to ICC net. But again, if you have a patient that you start on antivirals, you're a little bit worried about, you think, oh, I wonder how they're going to go over the weekend. Oh, look, please refer them to ICC net. That team is available 7 days a week to assist patients to do the daily check-ins, escalation pathways into the GP team here at SA Health. So please refer your patients across. You can fill in the form, or if it's an urgent, you can get either your practice nurse, or you can call yourself through to the clinical nurse mobile number if it's an urgent referral across. And there is that online referral form that we've sent out, and we can attach it on again into one of our GP updates. And I believe it is on Health Pathways as well. Remember, Health Pathways available to assist. And that team do a fabulous job of helping patients in the community. They get provided with the iPad, the blood pressure, the temperature probe, the oxygen sats probe as well. So really important that we connect patients in as much as we can into virtual monitoring services at home. So just wanted to give a bit of an update on ICC net. Broken up with the SAPath variant of concern, or where we see that genomic data. And again, this is actually last week's data that's come through. But again, you can see we are now really seeing that increase in BA5 becoming that predominant variant that we are seeing in the community now, consistent with what we're seeing in the eastern states as well. Just in terms of influenza, because I love putting a bit of influenza, as I said, we have seen that drop off, which is really pleasing to see. We're still seeing a median age range of 17, but again, remembering those individuals who are being tested, often it's children who are coming in to be tested, and so we do see a slight shift in where that detection is picking up cases in the community. And we have had, fortunately, no influenza-related deaths this year, which is very pleasing to see. There is just 5 days left of the free flu vaccine program as well. And a reminder as well, if you are performing flu vaccines within your clinic, then to send through your invoices through to SA Health so that we can organise for reimbursement for those vaccines. As I said, really pleasing to see those numbers dropping. So that red line there, much better. And again, number of influenza cases notified to date dropping off again. Now, we had questions before about reporting in of influenza. Yes, it is still technically a legal requirement to report in influenza, but we know that there has been considerable pressure on the phone systems as well to be able to report cases in. So online is the preference for influenza mandatory notification, and that's still a work in progress to see how we can automate some of these systems similar to what we are doing with COVID-19. Okay, so where are we now? Well, our aim is 99% of patients to be safely cared for in the community, being able to provide support from our high-risk team out to you as your patient's usual GP, but also the patients who that higher level care are COVID care centres. And this is where Eleanor comes into the picture, which is fabulous. Is how can we support patients further at home in the community? Apologies, I'm recovering from a post-viral cough, not COVID, thankfully, this time. Okay, so I'm just going to move through my slides here quickly because I just wanted to show something that I thought was really quite interesting. So this is really our pandemic lessons learned. And this is a great set of slides that have just been put together the last couple of days. We've had our hybrid clinical care models, and this is where we're coming into supporting alternative care models in the community. System navigation, primary care support. This is essentially what our team is aiming to do. And if you have suggestions of what we can do further to support you, please email through to our GP Liaison email address. We know there has been so much primary care support for COVID. We've had vaccinations, early diagnosis, the antiviral treatments, and really pleasing to see, SA has now overtaken the national average for antiviral PBS scripts as well. So a big, big thank you to all of our GPs who support in that process. Now, last time, you might recall, we had that really complex slide with Health Direct, different levels, mild, moderate, severe. What we've tried to do is to simplify it down so it's really easy, and we will be putting this up on our SA Health website as well. To make it clear, the patients in the community, they call through to the National Coronavirus Helpline, and then if they're in the high risk group, they're escalated through the SA Health Community Hub. And then we also have in place that clinician support line as well, which is available for you to be able to call in to the GP team, ask for advice, or refer your patient in that you're concerned about. You can do that through that clinician support line. And we have put that out, especially as well, out to our regional rural practitioners, so we can provide as much support as possible. And then we have a number of different clinical referral pathways. And this is where ICCNet, that virtual monitoring in the home, comes in. We can refer on to DATIS, we can refer on for COVID care centre support, or we can refer on for social work support, or through to SA housing if someone has accommodation issues and needs alternative assistance in that space. And again, 1800 313 090. That's the clinician support line available to come into our GP team 7 days a week, 8 a.m. to 8 p.m. And we can certainly help provide advice and referrals. And again, the rural regional outreach pathway is very, very similar, calling into that number, but that's to support around prescribing, and also particularly in areas where there's not community availability of the antivirals, to support access from the local health networks from the national medicines stockpile as well. So as I said, and this is the more in detail data, this is the sort of call volume that we're getting through from the National Coronavirus Helpline, usually around about 400 to 420 calls a day that are coming through from the South Australian community seeking that additional healthcare support. And since our high risk hub has been up and running, we have seen a considerable number of calls come through, 1,800 calls through our teams here. And very pleasing to see 188 scripts for antivirals have been provided through the hub as well. And then there's been some other prescriptions as well for Ventolin or other medications that particular patients may need. And very pleasing to see that we're seeing a large number of calls in the last week as well. So we're here to support. We're here to make it as easy as possible for your patients to be able to get access to care. And wonderful to see the GP respiratory clinics as well have really stepped up in terms of the oral antiviral prescribing, and we're very grateful for their support in this space, particularly over the weekends. And you can see 18 patients referred from the National Coronavirus Helpline to the GP respiratory clinics on Saturday alone. Hospitalisation data, so as I said, this is the data I presented at the very early on. We are seeing that slight increase up at a rate about 12 per day of increased admissions. And so we'll continue to track that number as it increases, and we hope to see a plateau in the next couple of weeks. And we're very grateful for that internal analytics to work through this. As I said, 98.6% at the moment in SA being managed in the community patients, and we would like to see what can we do further to support patients. So we hover around about that 99% number. We have ICCNet, 105 patients as of today in the system. And also the final point I wanted to mention, and then I'll leave and then I'll stop and I'll hand over to Eleanor, was the PHN support through the Metropolitan Referral Unit for face-to-face visits for patients who are COVID-19 positive. Now, this is the service, and we did send this out a while ago. We're very happy to send out more details on this. It is on the PHN, Adelaide PHN website, and also through Health Pathways as well. There is support for face-to-face visits the PHN have funded for patients who are COVID positive. And this is for the non-COVID care. So this is around wound dressings. If someone needs a blood pressure check, provided that you can provide, what is it that you need and the outcome and the follow-up. It may be, for instance, that your patient needs bloods done, for instance, that can be referred through this service, but then the follow-up, the clinical follow-up then comes back through to yourself rather than it being through the nursing team that the PHN have funded. But yes, we have seen reasonably low numbers through that program. So we'd love to see more patients referred through to that service. If you've got a patient who needs some eyes on scene, face-to-face review by one of the clinicians, then please refer through, and that's RN support from Wellbeing SA funded through the PHN. So please remember that service is available. That's probably it from me, and I'll hand over to Eleanor. As always, please post any questions you have into the Q&A box, and we've got Mel online as well, and we'll do our best to answer them. Thank you, Eleanor. A delight to have you join us this evening.
Yeah, thanks, Emily. It's been a real privilege to work with yourself and Mel and the team, and obviously with all our other partnerships with Adelaide PHN, Jenny Gould's teams, etc. It's been wonderful. So I've been working in COVID care by way of introduction since 3rd of January. I'm a GP and ED doctor by trade, so it's been a wonderful privilege. I think what I want to do tonight is share some clinical advice, both from telehealth and then what we can do extra when GPs find telehealth insufficient for their patients or they need that extra backup. So I've got experience in telehealth with the Women's and Children's COVID Kids and the COVUX helplines. We're doing telehealth here at SALHN, but it's the phone telehealth, not video. At the moment, but it's also that in-person review. So it's nice to have that hybrid model and those options, just like GPs in the community. So if everyone's happy, I'll just share my screen, and I'm happy to have as many questions, and Mel and Emily backing me up, of course. So I'll share my screen now. Okay.
Fabulous.
Is that showing properly, just as the whole screen?
Perfect.
Yep, beautiful. Cool. So SALHN COVID Care obviously has had executive sponsors and obviously the DHW and Emily and her team support as well. Carl and CCC set up before us, so they've been wonderful supports, and we've been linking in with Carlin, Narlin and the country LHNs and getting support from there as well. So it's been a really valuable service and really great supports. So what do we do here at Carlin? So we've been caring for adult patients with COVID-19, 16 years and up, and we're happy to see patients up to 28 days post onset of symptoms. So those patients that might have a secondary infection that starts at day 10 or 12, we're happy to see those as well. So we do face-to-face reviews. We can do urgent and semi-urgent. As cases go up, our capacity is being more strained, but can definitely get patients in the next day usually. Obviously been a big part of the MAB infusions at the beginning, now the antivirals, and we continue to support pregnant patients, especially over the weekend, if there's not capacity at the other site. So Flinders is still leading there, which is great, but obviously more care closer to home for most pregnant patients. So we don't just treat COVID, we also treat patients with other issues with the incidental COVID. And I think that was really good to hear about MRU offering those services as well for incidental COVID. I think that would be a great help over this winter. So we see minor injuries, and an exception to our 16-year-old and plus age group is the neonates. We've got a special neonate room for pregnant mothers or carers that need their children assessed. So what do we offer? We do those, we do care coordination, we can arrange Aboriginal liaison services, interpreter services. Obviously, the main thing is like, I'm a GP myself, part of primary care. So it's supporting GPs, supporting SAS, supporting ED avoidance, and supporting our vulnerable patients. I think the discharge planning, follow-up and education for patients is a huge bit of what we do as well. So in terms of referral pathways, I think most people have our numbers. I'll pop them up at the end. So one of our main core businesses is being part of the statewide antiviral model. I believe that's still SharePoint, and Mel or Emily could talk more to when that's slightly changing, but very happy to be part of that with Datas's support. Obviously, maternity and pregnancy, we see a bit more of that than maybe some of the other LHNs. So I haven't updated this GPAC now, the high risk hub. They've been fantastic. So we liaise with them quite a bit. And obviously SAS and the virtual care service, our emergency departments, GPs, Aboriginal health clinics. Very happy to take referrals from community and hospital specialists. And also, we do get consumers and patients cold calling. Sometimes we do book them in, but we do try and refer them back to that national hotline, especially now that the volume of calls is increasing. It's quite pronounced now, and I think that's a good thing as community awareness has increased. So in terms of phone telehealth versus video telehealth versus face-to-face, I don't want to preach to the converted or tell you guys what you're already probably doing, but I think it's important to remember just how much we can do over a phone telehealth assessment. We see about 20 plus patients face-to-face every day and do about 6 telehealth by phone every day at least. So if the patient's speaking in full sentences, has a normal voice, isn't in respiratory distress, I'm pretty happy that, okay, A and B are ticked off. Then we can ask about their circulatory history, and often patients already have a pulse oximeter, a heart rate monitor, or a BP machine. Now, one of the most useful things I've found for patients, and this is including myself, I didn't catch COVID at the COVID Care Centre. We have excellent PPE. I caught it from my lovely high school aged children. With the COVID cough, shortness of breath, it's real. But if I did my pulse oximeter reading and my SATs were 98, I was reassured and could go back to sleep. And so I kind of use the analogy with my patients of just like our mothers, grandmothers, etc. used to take our temperatures when we were little kids and they were reassured, they knew we didn't have to come to ED. I think that's the same for our patients now with the pulse oximeter often. Patients for years have been told, if you have shortness of breath, it's an emergency. And yes, that's true. But over the last 6.5 months, or we're coming up to 7 months, aren't we? What I've really seen is Omicron causes so much sensation of that tightness of the chest and shortness of breath that doesn't physiologically match. And the way I describe it to my patients, and happy to be corrected, is just like in the olden days, or patients still do go to the GP saying, oh, I've got a sore throat. I think I've got tonsillitis, but the GP has a look and they're like, no, it's just a bit red. You've just got a viral tonsillitis, and gives worsening advice, follow-up care, and topical and simple oral treatments. It's kind of the same with that chest pain often. I've got a slide about chest pain in general, but that shortness of breath and that tightness, often, even in those patients that are high risk, so I end up doing the full investigation workup as per protocols, as we must, it is often costochondritis, or it is often just that sense of inflammation. But I guess my role and our role as clinicians is to rule out those red flags, because they're very common as well, of course. So in terms of D, lots of diabetics, obviously, in the community. And a lot of them have their own BGL machines and or ketone strips. I think with the Flozins, just being mindful that you can get euglycemic ketoacidosis. So just to keep that in mind, and other exacerbations of chronic conditions. Now, the rashes with COVID, they do emerge just like we get other viral exanthems. So I've just stolen this from DermNet, so a little reference there. And I have seen, there's more on there, but these are the ones I've seen. And I guess it's like on history, because a lot of patients may think, oh, is the rash because of the antivirals I've started? Is the rash because of the antibiotics I've started for different secondary conditions? Really important on history to be able to distinguish. So these kind of maculopapular rashes, I've seen a few of these, and then on careful history about onset, it usually predates the antivirals. So I think being mindful that there are common exanthems with COVID as well. Now, in terms of a problem list, now I think it's great now for Paxlovid and other prescribing that now there's the level C telehealth. I know Mel and Emily were quite loud advocates, as was Danny Burns, etc. in South Australia, and I think GPs across the country. We were just like, please, we need level C for prescribing them, because there's so many potential contraindications and drug interactions. But if we're doing telehealth for what is essentially a viral presentation, it's going to be a level B. So what do we need to check? Is the patient got good respiratory status, or are we worried? What about their circulatory and hydration status, or are we worried? As you know, viral exacerbations of chronic conditions, everything from asthma to COPD to migraines, very common. And then, like any viral infection, is there a secondary bacterial infection? Complications of chronic conditions, so viral, inflammatory and others. So a lot of our patients that are going on to antivirals and are having some of their, say, rheumatoid medications held or other things held so that they can access the antivirals in the community, just being mindful, are they going to get a flare of their condition? So I think it's important to warn the patient or keep them in the loop about that. Co-infections. At the COVID care centre, I saw a beautiful little 20-year-old the other day, and the poor thing had COVID, but when I looked at her throat, I'm like, no, that's not normal tonsillitis. And sure enough, it was classic EBV that came back positive as an acute infection. So obviously she needed the hydration, the dexamethasone, the worsening advice for both COVID and for her EBV. Obviously, we're seeing a lot of patients that have got COVID plus para-influenza or influenza or rhinovirus or whatnot. So just being mindful that patients often have these staggered as well, especially if their kids are of daycare age. So doing those things can be relatively quick, especially if you know your patients well. Now, antivirals, do they need them? Are they indicated? I won't repeat what you already know. You've seen the new updated guidelines. And then not to forget VTE prophylaxis. So obviously, if your patients are already on apixaban or whatnot, it's not as big an issue, but especially in, say, overweight pregnant lady, it might be an issue. So just making sure you check off, do they need VTE prophylaxis? And then also about pregnant people, exacerbations of pregnancy-related complications. So we see a lot of patients whose hyperemesis is worsened by COVID. So basically COVID behaves like a lot of other viral infections, like influenza, where it exacerbates those underlying conditions. And then for me, the main thing is always that follow-up plan and safety netting. And that's where all these amazing partnerships that have been set up in South Australia come in so handy. So what are some of the common complications that I've been seeing? So dehydration is a big one. And so obviously by telehealth, we can arrange a lot, and you guys in the community can arrange a lot too quite quickly. So a lot of patients think they're doing the right thing. They're just drinking lots of water. But as you know, they need to alternate that with some hydrolyte or Powerade or whatnot. To really get rehydrated. Sometimes it's the nausea, so we get some antiemetics. Sometimes it's just that reduced appetite, like any viral infection. Other times there's vomiting and diarrhea that we need to address. Now, viral asthma exacerbations and COPD exacerbations, I'm quite stunned at the number of patients that come in and say, yeah, I'm taking 1 or 2 puffs of Ventolin every 2 hours and it's not helping. Okay, sometimes they're in acute asthma. We give them the rescue puffs, BioPuffer and Spacer, 12, 12, 12 plus some Attribute. But other times all they need is a bit of counselling, the nurses to give a bit of education and get them taking 6 to 12 puffs, 3 to 4 hourly. Some patients do want nebulizers that they've already got at home, and that's obviously not ideal, but we can provide those as well. But I think in terms of quick interventions over the phone to relieve symptoms when there's no red flags for patients, if they're asthmatic or on COPD, make sure they're actually optimizing their medications. Are they actually taking their Symbicort 2 puffs twice a day? I'm still quite stunned at the number of patients that aren't. They come in, they're presenting complaints, shortness of breath, they're obviously out of breath, they've got work of breathing, they've got some wheeze and chest tightness, and they aren't taking their medications optimally. So again, it's that role of education. Now, I think, again, having the pulse oximeter to take home. So if you need a pulse oximeter, you don't necessarily have to refer your patient to us for a face-to-face review. If the only issue is a pulse oximeter, they can either get a loved one who's not in quarantine to go pick one up from the chemist, or I'm more than happy, and our team is more than happy as part of ED avoidance to provide pulse oximeters for patients too. Migraine exacerbations are a big one. A lot of patients come in, they're dehydrated, they're viral, their migraines get worse. So in the non-pregnant patients, we do a lot of normal saline with Stemetal, obviously pregnant normal saline with Maxilon. In the community, again, making sure they've got adequate antiemetics and whatnot. Type 1 and type 2 diabetes, making sure that their sick day plans are adequate and that they're monitoring their BGLs adequately, staying hydrated, and obviously escalating it if the patients aren't. Now, a lot of patients that I see because of the referral pathways have chronic pain conditions, whether that's fibromyalgia or something like rheumatoid or psoriatic arthritis. And as you know, COVID causes that even in people without joint pain. So worsening arthralgias and myalgias, going through their medication plans and being mindful, again, like I said, do they need an increase in, say, prednisolone? I tend to always run that past their rheumatologist or whatnot to make sure. So tonsillitis is a big one, and patients, I feel for them because they feel like tight in the throat, they can't breathe. Some patients I have a look at, and yes, oh wow, they do have massive tonsils, and we give them some IV dexamethasone and fluids, and then they're happy. Other patients, though, they just really need to actually be taking their Nurofen and Panadol and doing their gargles because they're not. So again, I feel like I'm just saying all the basics that we all do for every viral illness. But again, it's that education that our patients are worried. Again, with the congestion, eustachian tube dysfunction, so the usual treatments we do for any other viral illness with eustachian tube dysfunction. And then I won't lecture GPs like myself on how to treat otitis media or sinusitis. The two I did want to mention is I've seen quite a few patients that have come in dizzy, so kind of young, healthy adults, usually healthy adults with COVID that are dizzy. And initially I'm thinking, oh, okay, it's going to be hypovolemia. That's what I usually see. But I've had at least 5 patients where they're not actually dehydrated and they've got that classic movement-induced vestibular neuronitis without any cerebellar signs. Without any central signs. So it's that peripheral neuronitis or labyrinthitis. So I think keeping that one in mind when people say they're dizzy, it's not always dehydration, although of course that's the most common cause I'm seeing. And again, I've put costochondritis with exclamation marks. I probably see that at least 5 or 6 times a day. It's the most common one I'm seeing. But again, like I said, we still need to rule out the serious causes of chest pain or tightness before we can diagnose that. So going on to chest pain. So risk assessment. I don't need to lecture this. If there's any registrars in the audience, I'm happy to answer more questions, but I won't for my senior colleagues. So basically, risk assessment, what are the potential serious life-threatening causes for that particular patient group that you're seeing? Some patients already have their pulse oximeter at home, or you can get them to count their respiratory rate, or you can see their effort, especially if you've got video telehealth. I find video telehealth is amazing. You can basically do a whole respiratory assessment by video telehealth. On the phone, a little bit more difficult. And then often you will need to do a face-to-face review for true chest pain. So the respiratory clinics are fantastic. At least, so the ones I visited is Ranella, and they can do ECGs and refer for chest x-rays if required, and they can do bloods. So it's great that those respiratory clinics are an option. Obviously, SAVCS supports the ambulances and yourselves if you're worried. COVID kids, obviously for peds. And then we see a lot of chest pain, and we see a lot that have gone to ED, but they're low risk for ischemic chest pain, and so they're sent down to us so that we can do the chest pain assessment that the patient is relatively stable, so that we can feel comfortable doing that, but we do have that access to ED if required. Now, I find the PERC score is extremely handy, because when do we do a D-dimer? When do we do a CTPA, like the D-dimer roulette? I don't want to be playing that with every patient I see. So I find the PERC score and the Wells scores are excellent tools for me to use clinically. I've seen, I think, only one PE this year that needed to be admitted, and a couple more that once respiratory saw them were safe for discharge. So usually with history and examination, I'm quite comfortable using the PERC score. In terms of cardiac risk, it's that low, medium, high risk protocols with the troponins and ECGs. I never forget about pneumothorax, because a lot of our patients are asthmatic, or they are young and tall, or what's going on. So quite happy to do chest x-rays. We see a lot of secondary bacterial pneumonia. Now, I wanted to do a shout out here to my home hospital. Previously, I was admitting any moderate secondary bacterial pneumonias to our COVID ward here at Flinders, but I've since found out that my home hospital can actually see stable, moderate pneumonias, and they can even do a bit of home oxygen if required. So I don't know if Mel or Emily will want to talk more about that, but I think don't forget my home hospital as an option. And I think that's really good, so that we can actually keep mild and moderate community acquired pneumonias potentially in the hospital. And I do see a reasonable amount of that. And obviously a reasonable amount of secondary bacterial COPD infections as well. And I think what's really great that obviously everyone does for their COPD patients is a lot of patients come to me, they've already started their pred and their antibiotics, and all I need to do is kind of reassure them, yes, GP's done the right thing, that's fantastic. Let's keep going, book in with your GP for telehealth in 2 days. Here's your COVID care kit, here's your pulse oximeter, here's your worsening advice. So I think the COPD patients have been managed super well in the community with their COVID exacerbations. It's been really good to see. Again, the costochondritis, it just comes up every day. But again, excluding the serious causes. So I never just think, oh, it's just this or it's just that. I do my history, I do my examination, I do my clinical assessment and the investigations as indicated, because like I said, we've seen a few PEs, seen a reasonable amount of secondary non-STEMIs as well. Touch wood, haven't seen a STEMI yet, but N-STEMIs aren't uncommon in the high-risk patients that are referred to us. And again, they're admitted as well. So we've got good direct admission pathways, so we don't have to at SALHN send them to ED if they're stable. They go straight to the ward. So I think we've sent 3 to ED and admitted about 40 directly, which is wonderful. We've seen about 3,000 patients, 2,000 for antivirals or MABs, and 1,000 for assessment. So I think that's pretty good that most of them get home. So when to refer to us? So we tend to get busy at the moment. We're looking at different ways to get our beautiful remdesivir patients for day 2 and day 3 back to the community. But probably that's the limiting factor at the moment, because that's one of our priorities. We're not seeing as much ED avoidance at the moment. But if you ring up, I'm very happy. And so all of our doctors are GPs with ED experience. So we've got Mary Liston, who I'm sure lots of you know, Katie Rogers and Emmy Bauer and myself at the moment. And I know there's some other GPs keen to work with us. There's always a GP on that's got ED experience. And I think that's really important about the COVID Care Centre, is we're there to support primary health and obviously the tertiary health as well, but we're there for the GPs and to keep patients close to home as possible. So if your patient's over 16 years or over and up to 28 days post symptoms, we're happy to see them for the various presentations. Like I said, doesn't have to be COVID related. Some of our things that we do is, let's say you've done a biopsy or you've done excision last week. Now your patient's got COVID, they can't come see you to get their sutures out. You can send them to us and we can take the sutures out. Like, our nurses are quite happy to do that. All of our nurses, again, are either ED or experienced ICU or very experienced ward nurses. So we've got a great nursing team. So very happy to help with things like that. We're seeing a lot of patients that have routine blood transfusions or whatnot. And we also support patients that might need a specialty team review. So if you've got a patient that needs to be seen by someone in Flinders, they can come to us and then they don't have to go up to the ward or whatnot if they're safe to be seen as that kind of outpatient scenario. Now, in terms of which antiviral patients to refer to us, I think, so like I said, DARDIS has been absolutely amazing, and I think GPs are just amazing. I use the analogy that it's like, when do we choose warfarin versus Clexane versus a NOAC? That's how I feel about the antivirals. That's my little analogy. I think it's that level of complexity. So I think usually we as GPs, we can do it ourselves, but sometimes we do need a bit of help, and that's when I call DARDIS or ID or the referring specialist. I find especially haematology and oncology are really fantastic at providing that support with all their rare different biologicals, etc. So I guess if you've got patients that don't meet the PBS criteria, we're more than happy to see them. Sometimes if they're stable, and we can do it by telehealth as well. So very happy to support complicated patients receiving antivirals, or ones that GPs feel strongly that they need it, but they don't meet the PBS criteria. I think that's probably and the care coordination. So one of the things I really enjoy, which reflects my GP-ness, is I like the care coordination. Like, the patients are a bit frustrated, their families don't know what to do, whatever's happening, we can arrange transport, we can arrange the face-to-face reviews, and I feel quite privileged that it's a luxury that I have the time to do it, and I've got the nurses and the admin to help me with that, because it can get, as I know, quite time consuming sometimes. So we can arrange medication pickups as well. So especially on the weekends, we often do that. So just last weekend, I was helping with one down at Meadows. We do a lot around Barossa Hills, Fleurieu, but also around the other country LHNs if required, just because, you know, everywhere's short staffed. So we're more than happy to help out, and we can fax scripts to pharmacies, etc. So it's quite rewarding to do that. Let me see. So the management that we can do, and that you guys all can do via telehealth, I think we sometimes underestimate how much we can do assessment-wise by phone. And for those of you that have video telehealth, even more. I think a lot of patients, they really need that education and reassurance and worsening advice, because like I said, everyone's been told, oh, if you're short of breath, if you feel tight in the chest, you have to come to ED. But a lot of these patients, what they actually need is just that assessment and reassurance. And if there are other red flags, of course, they do need investigation and whatnot. We can do antivirals, pulse oximeters with exclamation marks. Like I said, I actually think that's one of the best tools for patients with COVID to have in the community to monitor themselves and be reassured. Thermometers, the hydrolyte, antiemetics, salbutamol, there are other inhalers, oral steroids, and yeah, again, I'm preaching to the converted. So, but we can do all of that. And if you guys are finding any complications, or if you want some assistance, we're more than happy to help. So we can do face-to-face reviews, vital signs, education. Medication-wise, we obviously do orals, IV, etc. ECGs, chest x-rays and blood. So like I said, respiratory clinics do a lot of this as well. So we're not the only ones. VBG, ABG, we can arrange specialty team reviews on site, as said. For those patients that need it, we do ultrasounds. We have done CTs, so CT brains, CT abdos for patients that happen to have, you know, a head injury or a, abdominal pain requiring a CT. We also, obviously, for our pregnant ladies, arrange midwifery and, our CTGs and whatnot for review. The care coordination, the social supports, and minor procedures and intervention. So I'm just going to quickly share a couple of little stories, which I think just highlight how the CCC can fit in with all the other services. So probably my favourite, he was our oldest patient, was a 98-year-old. Now, his wife was in her early 80s, so quite fit. And he was a 98-year-old that had a permanent pacemaker and would have frequent pre-syncopes and frequent pacemaker interrogations. And he had one of these at Bunnings and was found to be incidentally COVID positive. So he was stuck on the ramp. So we brought him down to the CCC, did the full workup, the bloods, the ECG, discussed with the cardiac team, cardiac nurses, and then wonderfully, we were able to get him home with ICC net support. So he didn't need to wait on the ramp, wait in ED, be admitted overnight, and he was discharged home with support. And ICCNet provided a food package and daily follow-up for him and his wife, who were both incidentally COVID positive. Another one was, I guess it's just the community-acquired pneumonias I do enjoy helping. Another one that I did enjoy particularly was a young 18-year-old gentleman, and he had quite severe abdo pain, but on assessment he'd been managed with asthma he had asthma and was managed in the community completely adequately, but because he wasn't eating and he was taking high-dose steroids, he ended up with the gastritis. So we were able to do the workup, the bloods, the IV fluids, get him some pantoprazole, get everything settled, and then follow him up for the next 2 days. So I guess that just shows the spectrum of what we can do from 18 to 98. So I think that's probably enough of me talking for now. I'm happy to answer any questions, and just to let everyone know that, like I said, GPs and keeping patients in the community to look after them are our priorities, and really proud of what we're doing and really proud to be part of all the statewide services.
Fabulous. Thank you so much, Eleanor. And as you can see, Eleanor has a lot of practical advice, which is why we were so pleased that she was able to come and present to us this evening. So very much tips and tricks, how to manage really things that look really quite complex. Eleanor seems to break it down into very easy, simple terms. So thank you. I found that really, really, really helpful. And I will say, and we haven't had a lot of questions tonight. It's been a little bit quiet in the Q&A box, which is surprising, but we are absolutely here to support you if you do have any questions at all about navigating the COVID care centres. We do have the contact details as well, which we can send out. And we did just have a question around the SALHN CCC, but to emphasise, the SALHN site is really just focused on infusions. So this is particularly around the remdesivir pathways. That's where they need the 3 infusions, and SALHN is focused in that space. But there has been a really strong support from Sefton Park through the Carlin COVID Care Clinic, and a really grateful Jackie came in and worked over the weekend in that site so they could operate. Jackie, you do a fabulous job as she does in that space. And then we also have the Paraka GP Respiratory Clinic, which is also now open 7 days, and they have absolutely been seeing a lot of COVID positive patients for respiratory assessments, and then have been picking up antiviral prescribing as well. So there's those couple of options for patients who are in the north, but we are actively still working with SALHN. There's just some infrastructure issues around in space, but their ED has been seeing the COVID positive patients there. Yes, fabulous talk. Thank you, Eleanor. If there's no further questions, we might, I should have had questions prepared for you, but it was really comprehensive, all the things that you said, and we will absolutely send around those numbers again through the GP update. We're really, really excited to be able to expand the ICCNet. So again, if you've got a patient, you refer them into the COVID care centre, or you've assessed them yourself, maybe you've gone out, assessed them in their car, or you've had a home visit through the Wellbeing PHN funded service, then please don't forget you can refer them to ICCNet, particularly over the weekend, so you're not then worrying about your patient. And as Eleanor said, pulse oximeters are so critical in this space. So they get access to these kits and they deliver them out really quickly by courier service. So please, statewide system ICCNet. Now, the other question we've just had come in, and thank you so much, we've had a question come in around notifying COVID deaths in residential aged care facilities. And particularly, and then the second question was around the second dose of antiviral. So let's talk about the first one first, around the COVID deaths. It is still through the exact same process around notification. So filling out the form, it goes through the coroner, that gets compiled into a monthly update, and then every month we get through the data around COVID deaths that occurred in residential aged care facilities. In some cases, we have had palliative care teams go out from the LHNs as well to support in aged care facilities if there's been more complexities in that space, or if there's an issue around whether this is unexpected. Then absolutely, then some additional support can be provided through the LHNs. But just through the standard notification process in terms of completing a certificate, and then that comes into our monthly data. And you may have noticed, I think yesterday we reported 19 deaths, and that was data that had been reconciled through the community and had been done through the coroner. So it's not a mandatory notification, but the coroner's office do pull all that data through births, deaths, and marriages, and we get a monthly report from them to make sure that we're reconciling our data within SALHN. It usually comes at around about the 5th or 6th of every month. So we are a little bit behind in some of that data coming across. The other thing as well is it does also capture in our mortality data as well. We do capture if someone has had COVID previously. So sometimes in the last 3 to 4 months, we get some data through that shows someone has recently passed, but they had COVID, for instance, back in April. And so we just do a quick review and just to check to see was their death related to COVID. So there is a bit of a process that does occur where we do a bit of a look back. And the second part of that question was around second dose of antivirals. I don't know, Eleanor, if you want to provide a bit of what would you be doing in those cases where you have someone who's come in now, repeat infection, maybe had COVID in January, actually maybe they've had COVID in April and they did get access to antivirals at the time. What would you be doing now for them?
Yeah, no, thanks, Emily. As you know, we're well supported by the ID teams, and so often patients do qualify for a second dose of antivirals. I tend to seek guidance if required from DARDIS or the ID consultant. So Flinders has a specific ID consultant on call 24/7 that's the ID COVID consultant on call. So it's a different, when you bring Switch, you can speak to them if you do have any queries. So most patients that were eligible the first time will likely be eligible the second time. As the variants change and as there is some discussions about resistance, that's my understanding, that we just have to be mindful that it's an evolving field about which antiviral will be best. A lot of patients might have got sotrovimab early in the year, so now we can give them the best antiviral for them, whether it's Paxlovid or molnupiravir or remdesivir, but it is an evolving field, so I stay guided by ID and DARDIS.
Excellent. Thank you, Eleanor. You just reminded me when you were saying that about Evershield, which is being used as very important as a preventative medication. It's manufactured through AstraZeneca. That we did have some additional stock of that came through the National Medicine Stockpile sitting at the Royal Adelaide. If you did have any patients at all that you may think may be eligible for that, so meet that criteria around immunosuppressed and particularly focused on renal dialysis patients, then please let us know. There is availability for that to be administered out. We do have a small amount, and that can be done through the ID team, and we can link you in through to Dr. David Shaw's team at the RA. But if anyone does have any patients who think may be eligible, please let us know. We've never actually done a public email out for referral requests because it's been managed through the public hospital system and the physicians there. But I'm just conscious that you may have a patient in the community who's has not been linked in, and I do know that there is some additional stock available, supply of those medications. I'll leave it there. Thank you so much, Eleanor. Brendan, I'll hand back to you.
So much.
Thanks, Emily. Thanks, Melanie. And of course, Eleanor, special guest. It was a fabulous presentation. And thank you all again. And hopefully we'll do this in the next couple of weeks. Thank you.
Thanks, everyone, for joining us.